Talking about aortic valve disease. So the two aortic valve disease that we need to cover would be aortic stenosis and aortic regurgitation. First, we will start with aortic stenosis. Aortic stenosis means there is a stenosis or a tightening of the aortic valve. So what are the symptoms of aortic stenosis or a stenotic aortic valve? Commonly it is seen in elderly population, and you have a symptom triad: exertional dyspnea, exertional angina, and exertional syncope. So whenever you have these three symptoms, we should think of aortic stenosis in an elderly patient. Now, what are the etiologies for aortic stenosis? Usually it is rheumatic heart disease, but now it is not that common, and now you have congenital bicuspid aortic valve, which is a common cause for aortic stenosis. You can have atherosclerotic aortic stenosis and calcific aortic stenosis. What are the physical examination findings that we get in a patient who has got aortic stenosis? We will first start with the pulse. So when you examine the pulse in aortic stenosis, you get a low volume, slow rising pulse, which is called an anacrotic pulse or pulsus parvus et tardus. This is characteristic for aortic stenosis. Next, coming to the blood pressure. When you record the blood pressure in aortic stenosis, you will get a narrow pulse pressure. Otherwise, it is known as systolic decapitation of the systolic blood pressure. So the difference between the systolic blood pressure and the diastolic blood pressure will be narrow, maybe around 20 to 30 millimeters of mercury. Coming on to the examination of the cardiovascular system in aortic stenosis, when you examine the apex, you will get a forceful and sustained apex, which is otherwise known as a heaving apex. So a heaving apex is characteristic of aortic stenosis. And you may also get a systolic thrill at the apex and the aortic area. Now when you auscultate in aortic stenosis, you will get a rough rasping ejection systolic murmur in the aortic area, which is transmitted with the same intensity to the carotid, and hence we say there is conduction of the murmur to the carotid. Now if it is a valvular aortic stenosis, you will get an additional heart sound which is called aortic ejection click. It is a systolic heart sound. Now the aortic ejection systolic murmur, which is heard classically in the aortic area, can be selectively propagated from the aortic area to the mitral area, and this phenomenon is called Gallagher's phenomenon. Now, what are the complications that you can develop with aortic stenosis? Now, we already mentioned you can have exertional dyspnea, exertional angina, you can develop an acute coronary syndrome, you can develop syncope, you can develop infective endocarditis, you can develop ventricular arrhythmias, and a very important complication that is seen in patients with aortic stenosis is sudden cardiac death. Okay. Now, a very close differential diagnosis for aortic stenosis will be aortic valve sclerosis, where there is degeneration of the aortic valve which occurs in elderly individuals. So in such patients, in order to differentiate from aortic stenosis, if you examine the pulse in a patient who has got an aortic valve sclerosis, the pulse will be normal, the blood pressure will be normal. When you palpate the apex, it will be a normal apex, and on auscultation, you will get an ejection systolic murmur, but when you focus on the aortic component of the second heart sound, it will be normal. Whereas in aortic stenosis, which I failed to mention earlier, when you auscultate for the second heart sound or the aortic component of the second heart sound in the aortic area, the aortic component or the A2 will be soft. So to differentiate between aortic valve sclerosis and aortic stenosis, all these points will help, and especially on auscultation, if the second heart sound or the aortic component of the second heart sound is normal, it is more likely to be an aortic valve sclerosis, which is also very commonly seen in elderly patients. But if an elderly patient has got features of an necrotic pulse, narrow pulse pressure, a heaving apex, and an ejection systolic murmur in the aortic area which is conducted to the carotids, and the second heart sound being soft and having an aortic ejection click, all these point towards diagnosis of aortic stenosis. Now, what is the lifespan or expectancy in aortic stenosis with symptoms if they do not undergo any treatment? Now, a patient with aortic stenosis who has angina has a lifespan of 4 years if they do not undergo any treatment. A patient with aortic stenosis having syncope will have a lifespan of around 3 years, and a patient with aortic stenosis who has gone into heart failure will have a lifespan of around 2 years, provided they do not undergo any definitive treatment. Now, the investigations that you can do in a patient with aortic stenosis will be to take an ECG, which will show left ventricular hypertrophy. You can do an echo, which will show the concentric hypertrophy of the left ventricle and also the pressure gradient across the aortic valve. And the definitive treatment for aortic stenosis is aortic valve replacement. But before you do an aortic valve replacement, especially most of the patients are elderly, you should also subject them to an angiogram to rule out any coronary artery disease. Because if coronary artery disease is present, then you can do both the procedures simultaneously, namely aortic valve replacement plus a coronary artery bypass graft. So that is as far as aortic stenosis is concerned. Now we will discuss the second lesion about the aortic valve, which is aortic regurgitation. Aortic regurgitation means the aortic valve is leaking. So in aortic regurgitation, what are the etiologies? Now usually acute aortic regurgitation is due to infective endocarditis, rheumatic valvulitis, rupture of sinus of Valsalva, aortic dissection, and trauma. There are other etiologies for developing aortic regurgitation, and they include syphilis, rheumatoid arthritis, ankylosing spondylitis, Marfan syndrome, Ehlers-Danlos syndrome, congenital bicuspid aortic valve, Takayasu's arthritis. So what we need to remember is the causes of acute infective endocarditis, acute aortic regurgitation, which is due to infective endocarditis, rheumatic valvulitis, rupture of sinus of Valsalva, aortic dissection, and trauma. Now, what are the symptoms that we come across in patients with aortic regurgitation? Now, in aortic regurgitation, due to leaking aortic valve, they will have a volume overload of the left ventricle. So, they often present with exertional dyspnea, they present with palpitations, they can present with angina in severe aortic regurgitation, and they can also present with heart failure. So what are the physical examination findings with respect to the pulse, BP, and cardiovascular examination in aortic regurgitation? The classical pulse that we get in aortic regurgitation is a high volume collapsing pulse or a water hammer pulse. When you record the blood pressure, you get a wide pulse pressure as opposed to a narrow pulse pressure that you get in aortic stenosis. When you examine the precordium for the apex, you will get a forceful apex which is ill-sustained or a hyperdynamic apex. And the apex is usually shifted downward and outward. That is, the patient will be having a cardiomegaly. On auscultation, in the aortic area as well as the neo-aortic area, that is the third left intercostal space, patient will have a high pitch blowing decrescendo early diastolic murmur. This early diastolic murmur is best heard in the neo-aortic area or the aortic area with the diaphragm of the stethoscope, with the patient sitting and leaning forward and breath held in expiration. This would be the auscultatory finding in classical aortic regurgitation. But in severe aortic regurgitation, sometimes on auscultating the aortic area, you may get an ejection systolic murmur as well. It can be either a combination of aortic stenosis and aortic regurgitation, or it can be a severe aortic regurgitation where you have an ejection systolic murmur in the aortic area and an early diastolic murmur also in the aortic area and the neo-aortic area. Sometimes in severe aortic regurgitation in the mitral area, you may get a mid-diastolic murmur, and this is referred to as the Austin-Flint murmur, which is seen in severe aortic regurgitation. Now, there are peripheral signs which are seen in aortic regurgitation, and these peripheral signs are as follows. It is not necessary to remember all these signs, but a few peripheral signs. Now, on the forehead, you can have flushing and blanching of the forehead, which is called lighthouse sign. If you look at the eyes, you may see an alternate dilatation and constriction of the pupil, and that is referred to as Landolfi's sign. If you can examine the retina, you can see retinal artery pulsations, which are referred to as the Becker's sign. If you examine the uvula, you will see that there is a pulsating uvula, and that is referred to as Muller's sign. If you look at the neck, you may see very prominent carotids, and that is referred to as the dancing carotids or the Corrigan's pulse. Sometimes patients with severe AR or aortic regurgitation will have a head nodding, and this head nodding sign is known as Alfred de Musset's sign. If you examine the cubital fossa, you will see very prominent brachial artery pulsations, and that is known as the locomotor brachialis. If you examine the nails, you will get alternate flushing and blanching, which can be demonstrated even better by using a glass slide pressed upon the nail, and this is referred to as Quincke's pulse. Coming to the lower limbs, if you record the blood pressure on the lower limb, the difference between the systolic blood pressure of the upper limb and the lower limb usually is less than 20 millimeters. So if the difference in the systolic blood pressures of the upper limb and the lower limb are between 20 to 40 millimeters of mercury, it is a mild aortic regurgitation. If it is 40 to 60, we call it moderate aortic regurgitation. And if it is more than 60, we call it as a severe aortic regurgitation. Now, when you auscultate over the femoral arteries also, you can get pistol shots, and they are often referred to as the Traub sign. If you apply proximal pressure to the femoral artery, you can get a murmur, and if you apply a pressure distally to the femoral artery also, you can hear a murmur in systole and diastole respectively, and this is referred to as the Durose's murmur. Now, you can also have hepatic pulsations in aortic regurgitation, which is referred to as the Rosenthal sign, and you can also have splenic pulsations in aortic regurgitation, which is referred to as the Gerhard sign. Now, how do you grade the severity of aortic regurgitation? Now, in mild aortic regurgitation, there will be no wide pulse pressure, there will be no peripheral signs, but you only get an early diastolic murmur on auscultation. In moderate aortic regurgitation, you will have a wide pulse pressure, you will not have any peripheral signs, and you will get an early diastolic murmur on auscultation. In severe aortic regurgitation, you will have a wide pulse pressure, you will have the peripheral signs of aortic regurgitation and you will have an early diastolic murmur as well. Now, what are the complications that a patient with aortic regurgitation can develop? Patients with aortic regurgitation can develop infective endocarditis, they can develop acute left heart failure, and they can develop ventricular arrhythmias. And patients who have got severe aortic regurgitation, the definitive treatment will be aortic valve replacement. Thank you.